Hi there, I'm Dr. Sloan with Boise Prosthodontics. I'm here also representing Dr. Jones and Dr. Gurney, and this is a video supplement to our quarterly newsletter. We've never done this before, but we'd love to hear your feedback and see if you think it's helpful or if you learned anything from it. What we wanted to do today was go through a case that we outlined in our newsletter. The reason we wanted to do this is because as we're writing these cases up, many times we realize that we just can't fit everything in that we want to. There's just so much that goes unmentioned or that we have to cut out. So we thought, why not give it a shot to talk about it? And this is a wonderful patient. Dr. Jones performed her case. We really enjoyed getting to work with her. She came to us a little bit distraught about her previous restoration. This was done a few years ago. And obviously there's been some concerns here. There was a breakage there between the prosthetic tooth 10 and 11 and the pink is having a hard time adhering to the acrylic. This is an acrylic restoration, and so the patient at the time was not happy with the relationship she developed with her dentist, and over time she became less and less happy with the prosthetic as well. So she was referred to our office. As you can see from the side views here that we have some aesthetic concerns that we mentioned. The teeth are also wearing. This acrylic does really great in the short term. It does not do great over the years. And there's the fracture line. As you're looking at the prosthesis here, you can see there's a large flange up at the front for a fixed prosthesis. We don't want that, and we're going to go over that in some detail for this presentation. This is a view of the occlusal, the breakage, some of the wear can be seen, and the mandible. So when we saw her, we did a diagnostic workup. We looked through her case, gathered all the data that we could, photos, records, scans, cone beam, and a comprehensive thorough dental exam. Our main findings were obviously ailing and failing implants and failing prostheses, non-cleansable prostheses, and a limited restorative space in the maxilla. As we go through, though, there's a lot of different things to discuss with the patient, and we were able to have those discussions with the patient. Some of the things that were a result of our diagnostic workup, and things that we discussed with the patient were the objectives of her treatment. What exactly did she want? What was she not happy with? What were her goals? The plan that we proposed to her we'll go over here in a minute, but we also let her know what the alternatives could be. We made our recommendation with the patient, but we also wanted to take into account the patient's preference, and sometimes those don't always go hand in hand. We had to go over the pros and cons of each alternative, of each option, the risks and the benefits of each, and understanding that in certain scenarios, especially trying to save and use old implants, that many times you have to accept compromises versus always seeking the ideal. And so there's a balance there as well. Finances were discussed, the sequencing of how long would this take and what does it entail, and then the prognosis of each option. So just as a spoiler alert, this is the final post-operative panoramic radiograph, but what it does is it allows us to visualize the final chosen treatment plan after those discussions. And you can see in the maxilla that we chose to maintain and salvage 5 of her existing implants. There was one failing implant on the upper left that was replaced with a zygomatic implant, and all of her mandibular implants were removed and replaced. And then prototype and then final all-in-X prosthetics were delivered. So what we want to go through here with this case is some very specific treatment challenges that we came across. Namely, the ramifications of keeping overly shallow implants caused a conflict here for us. And what I mean by that is that when we're designing a fixed restoration, there are some principles that we try to follow in the realm of aesthetics, hygienics, and function. In this case, aesthetically, we always want to design an FP3 style restoration to have the transition line hidden behind the upper lip. And we always want to make sure that it looks really good, basically. Hygienically, we always want to design these restorations so that they can be really easily cleaned. Let me show you what I mean. So the ideal contours of a fixed restoration are cleansable, meaning that they're flat to convex, there's no flanges or ridge laps, there's no concavities that food can get into and be stuck in and not be cleaned. Obviously, throughout the day, food will collect around the prosthesis, but the goal is that after a meal, that most of that can be swished away, and then at night, all of it can be cleaned away because there's nowhere that the food can get trapped and not cleaned out of. We can see in some cases like this, this was not the patient's restoration, but showing flanges on these fixed restorations and concavities. And these collect food and trap food in a way that the patient is not able to clean out even with the best hygiene at night. And so in this patient's case, we made a prototype for the patient, just meaning a temporary prosthesis made of acrylic with composite pink gingiva. But we made it in a way that follows those ideals and those principles of a hygienic restoration. And as you can see, it did reveal the presence of her abutments. Now, those abutments, we did choose to leave those and not replace those or not go straight to implant. So it's primarily due to the angulation of the implants and needing to use angle correcting abutments. And so there they are. You can see them above the prosthesis, previously hidden by the flange on the other prosthesis, and you can see this shaded area represents the size of the flange or the non-cleansable concavity that was created in an effort to hide all of that. So in FP3 prosthesis, as I mentioned, we always want to have that transition line between the fake pink and the real pink, between the patient's gingiva and the prosthesis. We want to have that hidden behind the upper lip, like with this patient. And so that's some of the ideals that we were striving for in her case, but we ran into some issues. And so the issues that we ran into had primarily to do with the patient's smile dynamics and understanding that. And so as we're diagnosing and treating these all-in-X cases, it's really important that we do so with an understanding of the patient's smile dynamics. One of the first things that we look at. This patient is a great example of, and this patient is outlined in our clinical pearl in the newsletter. This patient is a good example of somebody who has multiple smiles. So over on the left there, in repose, the patient might show just a little bit of tooth. They're capable of kind of a low, fake, business type smile, or a genuine high smile. You can start to see the eyes engaged there. And then there's the ultra high smile, when they're laughing and super happy and not thinking too much about anything, and that lip can really elevate a lot, especially in certain patients. So back to the case, this patient was one of those where she had different smiles for us. There was kind of the business smile here, the genuine smile, and then the ultra high smile where her lip just hikes up enough to where all the abutments, the ridge, that transition line are totally visible. And so aesthetically, this is a problem. This is a challenge for her case. As we're doing these, once again, it's really important that the patient's smile dynamics before the implants are placed is analyzed, because what that does is it drives our treatment planning in such a way that we need to lay out 3 different lines, or 4 really. The first is understanding where the teeth need to go, not necessarily where they start out, or with a patient's existing denture or a patient's existing teeth in a terminal dentition case. So we need to understand where the patient's high smile line is, where they're physiologically capable of elevating their lip, as shown in the green line here. We need to understand then that beyond that, 3 to 4 millimeters beyond that, or hidden behind that, we want the implant, or we want the transition line, the patient's ridge essentially, and maybe the tops of the abutments. And then 2 to 3 to 4 millimeters beyond that, as the abutments connect with the implants, that's where we need the bone reduction line or the implant platform line to be placed. So as we analyze the smile, it drives all of that treatment planning up to where the implants are, where the lip is, where the patient's ridge is going to end up. And we can translate that and correlate that directly with our cone beam before implant placement to be able to plan all of that on one screen. And it really allows us to see the case, see the end from the beginning before a scalpel is ever picked up. And so back to the case at hand, we can see that those lines are out of order, that the transition line between the patient's gingiva and the false gingiva between the prosthesis and the tissue is exposed, it's visible, and the other 2 lines about where the implant platform is and the high smile line basically coincide or are very close. So what we needed to do in this case is to find a solution. And the solution that we settled on was to have essentially minor compromises in both hygiene and aesthetics instead of having to have a major compromise in either. And what I mean by that is the patient came in with a flange that totally hid her abutments and the transition line. And you could say that was an aesthetic choice. Obviously, there were other aesthetic concerns with the restoration, but it was not a hygienic choice. Alternatively, some of those prototypes that we ran the patient through were hygienic choices, where we had the prosthesis shaped in such a way that it followed all of the principles of good hygienic restorations, but it was a huge aesthetic compromise, where if the patient forgets and hikes her lip up a little bit if she's laughing, she just shows way too much of the abutment and way too much of her natural tissue. And so what we decided to do was find a sweet spot in the middle where the patient can have a prosthesis that's cleansable, maybe with some little bit of challenges, but also aesthetic, and as aesthetic as we can make it. And this shows the final restoration. And what you'll see here is that there's these very strategically placed minimal flanges right where the abutments are, which don't entirely hide them, but it gives the patient a little bit more wiggle room to not show as much metal if she does elevate her lip. And so once again, this is a hygienic compromise because now the patient has these little flanges that will collect food more than they otherwise would, and would cause the patient to have to do a little bit of extra hygiene as she goes home. And what we also have here is that the patient, from an aesthetic perspective, did have to learn how to not elevate her lip to that ultra high smile line. And once again, we tried to hide the abutments a little bit if she ever did, but the patient did also learn to keep that lip just a little bit lower, which is an aesthetic compromise. We really want our patients to be able to conform to our dentistry, or we don't want our patients to conform to our dentistry. We want to build our dentistry to their mouths and their smiles and what they have. But in this case, the patient did have to learn to not hike her lip up all the way so that she wouldn't hide those abutments. And once again, all of this stemmed from that decision that the patient made with us together to salvage those implants and not replace them. And rationale behind that, we don't necessarily, that's not the objective to go into when to save implants, when to take them out. But that was the chosen treatment plan, and this was the outcome, is that we had to meet in the middle and have a restoration that tried to address these challenges that came up. And so we thought this was a really great case. The patient was really enjoyed her final outcome. We really feel like the patient had a better smile when she left, a better prosthesis, and a better quality of life than when she came in. She understands those challenges with her hygiene, needing to be able to keep everything clean, but also with her smile, that she may not be able to elevate her lip to that ultra high smile line. But all in all, with this chosen restoration, the patient was really happy. We outlined in our newsletter some of the things that she said, but she's very happy, and we love seeing her around because she's just has such a pleasant personality. And so this was the case that we wanted to show and wanted to document and outline. And here at Boise Prosthodontics, this is really what we do on a daily basis, is just taking situations with implants or with full mouth rehabilitations or with dentures, anything like that, where might be challenging, or there might be some patient demands that are challenging. There might be some implant complications or implant requirements that are challenging, and we like to be able to solve those issues. And so there's a lot of ways that we would love to be able to work with you, with any of the docs here in the Treasure Valley or anyone from the surrounding areas. And that could involve, if there's a case that you just don't want to treat, we'd love to have it if you want to send it over. If there's a case where you just need to ask a few questions, we'd love to field an email or a phone call, and anything in between those. Sometimes there are complications that we'd love to help you work through. Sometimes there's a case that where things can be split up, and you would just like us to help with maybe an oddball implant case or an oddball implant scenario. Any and all of the above is welcome, and we'd love to be able to collaborate with you on these cases. We are specialists in prosthodontics, and we especially love to be able to help with these all-on-X cases. One thing that we are trying to do more of is to collaborate with you throughout the entirety of a case. And so if you have a case that with a patient that you would love to see treated, or you'd love to have us work up the patient and do the surgery and the conversion with you, and you deliver the final, or any combination of any of those things, just give us a call. We'd love to be able to chat about it and look at the case, see what the challenges might be, just like with this one, and work through them. So we're here to help you out. Our goal and our mission here at Boise Prosthodontics is to be an extension of your team and a resource for your practice. If there's any way that we can do that for you, we'd love to be able to talk about it. Thank you so much.